Hello friends, welcome back. In continuation with our lectures on arrhythmias, in the last class we had learnt about the approach to tachyarrhythmias and about supraventricular tachyarrhythmias. Today we will be discussing about ventricular tachyarrhythmias. Okay. So, in ventricular tachyarrhythmias or in ventricular tachycardia, what are the characteristic clinical features? So, there is a heart rate of more than 100 beats per minute and there is a broad complex tachycardia. There is a heart rate of more than 100 beats per minute and a broad complex tachycardia. And the most important feature is that there are no P waves. There are no P waves. Okay. So, the first of the one that we are learning is what is your ventricular premature complex. What is your ventricular premature complex? So, can you see here in this rhythm that there is a normal PQRST, then there is a normal beat, followed by which you are seeing a broad complex, QRS complex which does not have a P wave. This is a broad QRS complex which does not have a P wave and it has come earlier than the expected next sinus beat. This has come earlier than the next expected sinus beat. So, what is this? This is what we called as a PVC or a premature ventricular complex. Why do we call it a premature ventricular complex? Because this is a broad complex. This is a broad QRS morphology complex and it is arising from the ventricle. Okay. Now, followed by this PVC, can you see that there is a pause? So, this time period between the two normal beats which straddle a PVC is what we call as a compensatory pause. Then, the time from the previous T wave to the arrival of the PVC. The distance or the time between the previous T wave, the T wave of the previous QRS complex which is a normal one, the T wave of the previous beat which is a normal beat and the time between that and the PVC is what we call as the coupling interval. Okay, this is what we call as the coupling interval. So, what is the importance of the coupling interval? So, if the coupling interval is short, don't you feel that the PVC will fall on the T wave of the previous sinus beat? It will fall on the T wave of the previous beat. This is what we call as a R on T phenomenon. So, whenever we have short coupled PVCs, or VPC, ventricular premature complexes, what happens is that this can trigger a run of VT or VF. It can trigger a run of VT or VF. So, if there is a run of VT or VF, it can often be fatal. So, this is what we call as a R on T phenomenon. So, short coupled VPCs are dangerous. Okay. Now, when do you call it a VT? You call it a ventricular tachycardia when there are more than 3 PVCs in a row. When there are more than 3 VPCs in a row, we call it ventricular tachycardia. Okay. Now, let us look at how you classify this VT. How do you classify this VT? So, based on the morphology, it is classified as monomorphic, polymorphic and pleomorphic VTs. So, based on the morphology, it is classified as monomorphic, polymorphic and pleomorphic VTs. So, monomorphic, as the name suggests, the QRS complexes are of the same morphology, something like this. Okay, so they are of the same morphology. So, what is a polymorphic VT? In a polymorphic VT, the QRS complex morphology changes with every beat. Okay, so you can see that there is a complex like this, then there is a complex like this, then there is a complex like this, then like this. So, this is your polymorphic VT. Now what is a pleomorphic VT? In a pleomorphic VT, you can have more than one QRS complex morphology. You can have more than one QRS complex morphology, but it does not undergo continuous change. Okay. So in lead 1, you may have a morphology like this. In lead 3, you may have a morphology like this. Okay. So there are different morphologies, but with every beat, they do not change. But in a polymorphic VT, within the same lead, you can see that with every beat, there can be a change in the morphology. So that is the difference between your monomorphic, polymorphic and your pleomorphic VTs. Okay. Now, let us understand certain characteristic features of the ECG of VT. Okay. So first you have to understand is that there is a fusion beat and a capture beat. So what is the meaning of this fusion beat and capture beat? So we all know that VTs are arising from where? They are arising from the ventricle. So will they have a P wave? No, they will have no P waves. So the ventricle is beating on its own. Okay, so it's not under the control of the SA node, right? So can you see here in this ECG that there are broad QRS complexes suggestive of ventricular origin? Suddenly there is a complex which looks like a PVC is combined with a sinus impulse, right? So there is a mixed type of a complex, and this is what we call as a fusion beat. This is what we call as a fusion beat. Okay. Now, what is a capture beat? Sometimes the SA node can capture the ventricles. Sometimes the SA node can capture the ventricles, and then can you see here it follows like a sinus beat itself. So it follows like a sinus beat itself. So this is what we call as a fusion beat and a capture beat. So the presence of a fusion beat or a capture beat is a characteristic of ventricular tachycardia. Then the next thing that you have to know is the presence of what we call as the Josephson's sign. So what is this Josephson's sign? So sometimes in a ventricular tachycardia, you can have slurring. You can have slurring in the descending part. In the descending part of the QRS complex, you can have some amount of slurring. This is more appreciable in the leads V1 and V2. This is what we call as the Josephson's sign. Okay, you can appreciate some amount of slurring in the descending portion of the QRS complex, which is more appreciable in the leads V1 and V2, and this is what we call as the Josephson's sign. Then we look for something called as the Brugada's sign. So what is the Brugada's sign? The distance between or the time taken from the beginning of the QRS complex to the peak of the S wave. If it is more than 100 milliseconds, it is suggestive of a VT. Okay, so from the beginning of the QRS complex to the nadir of the S wave, if the time taken is more than 100 milliseconds, then it is suggestive of a VT. Okay, this basically means that it is an extremely broad complex. Fine, so that is your Brugada's sign. Then most of the VTs show concordance. That means, what is the meaning of concordance? That means that if they are positive in lead 1, in all the leads they are positive. Okay, so this is what we mean by concordance. If it is negative, then it is negative throughout. So concordance is a characteristic feature of VT, and the most important is that there is definitive AV dissociation. So that is about the different signs that you find on the ECG of ventricular tachycardia. So this is the ECG. Can you see that there is a concordance? What type of concordance? There is a positive concordance, right? This is a positive concordance. Then you can see extremely broad complexes. Okay. So that is about your ECG of the ventricular tachycardia. Fine. Now let us look at what are the etiologies. Let us look at what are the etiologies. So you can have idiopathic, ischemic etiology is very, very important, because when you have a large ischemia, you can cause a lot of electrical instability and they can have a VT. So we have learnt in the complications of MI that any ventricular tachycardia that arises in less than 24 hours after an MI is called a primary VT, and more than 48 hours is your secondary VT. Cardiomyopathies, right? So, cardiomyopathies include what? Cardiomyopathies include what? So, they include your Chagas disease, arrhythmogenic right ventricular dysplasia, genetic conditions including laminin A and C mutations. So, laminin A and C are muscle proteins. So, genetic conditions which affect this laminin A and C can predispose to ventricular tachycardias. Then other cardiomyopathies include HOCM. Then we have something called as scar VT. A scar VT, for example, when you do a surgery such as in a repaired TOF, you can have a scar VT. Then other genetic conditions include your long QT and Brugada syndromes. You have learned what is your long QT syndrome and what is your Brugada syndrome in your class on basic approach to ECG. Fine. Now, let us look at the management of monomorphic VT. In a stable patient, you can give antiarrhythmics which includes amiodarone, calcium channel blockers, beta blockers, sotalol. In an unstable patient, you have to do a synchronized DC cardioversion. So, what is the meaning of that? So, if these are the VT waves in a cardioversion, what you do is that you press the sync button. So, when you press the sync button, what happens is that there are dots which appear like this. So, these dots means that the electrical impulse will come only when the peak of the QRS complex is detected. So, the electrical impulse will be provided only at the peak of the QRS complex. So, that is why you need to give a synchronized cardioversion. What happens if you give a defibrillation where it is not synchronized? So, if the impulse comes here, what will happen? We have just learnt there can be an R on T phenomenon, and this can in fact result in a VF and it can result in an arrest. That is why you need to do a synchronized cardioversion. Okay, let us go to the next part, which is your polymorphic VT. The polymorphic VT is also called as Torsades de Pontis. Okay. So, can you see here that there are different morphologies of the QRS complex with every bead similar to a wave. So, this is what we call as the Torsades de Pontis. So, what is the etiology? Congenital long QT syndromes which can be due to potassium or sodium channel defects. Then, electrolyte disorders including hypocalcemia, hypokalemia, hypomagnesemia. Drugs including class 1A and 3 antiarrhythmics. Macrolides, fluoroquinolones, SSRIs, TCA. All of these are associated with acquired long QT and they can predispose to Torsades de Pontis. Endocrine disorders including hypothyroidism, theochromocytoma, hyperaldosteronism, and secondary to cardiac disorders and even intracerebral hemorrhage. So, these are the various etiologies of Torsades de Pontis. So, what happens when you have a Torsades de Pontis? You can have a fatal arrhythmia and cardiac arrest. So, the treatment would be to defibrillate. And then you administer 2 gram IV magnesium sulfate. So, the drug of choice would be magnesium sulfate. Okay. So, that is your Torsades de Pontis. Now, let us understand what is an electrical storm. So, when more than 3 ventricular tachycardias, when more than 3 episodes of ventricular tachycardias occur within 24 hours and it requires intervention to terminate. This is what we call as the electrical storm. So, how do you manage an electrical storm? First thing, you have to stabilize the rhythm. First thing is that you stabilize the rhythm. So, you defibrillate the patient so that you stabilize the rhythm. Okay. Then, you will have to relieve the trigger. Okay, you have to find out if this is ischemic and there is a VT, then you do a reperfusion. Okay, you correct the underlying abnormalities, you correct the dyselectrolytemia. If it is because of an inflammatory condition such as giant cell myocarditis causing the VT, then you can give steroids. Then we do something called as overdrive pacing. You do something called as overdrive pacing. What is the meaning of that is that you do a pacemaker and you generate or you give a stimulus which is at a higher rate than that of the VT. So what happens is that when you give it at a higher rate, then it terminates the VT. It terminates the VT. So this is what we call as the overdrive pacing. Fine. If it is a Brugada syndrome, you found out that it's a Brugada syndrome which is causing your electrical storm, then you can give calcium channel blockers or minidine. The third part of the management would be to reduce the sympathetic drive, right? So in many types of VT like catecholaminergic polymorphic VT, it can be because of a sympathetic drive. So in those conditions, you have to give beta blockers, you sedate and intubate the patient and see if the VT can come down, and then you look for the other causes and other forms of management for VT. So these are the three major pillars in the management of electrical storm. Okay. Now, what about ICDs? What are ICDs? ICDs are basically implantable cardioverter defibrillators, right? We know of this. So, ICD is basically placed in a subcutaneous pocket and this is used for prevention of VT. So, whenever there is a VT, the ICD will detect the rhythm and will give a shock and terminate the VT. So, that is a basic function of ICD. But in an electrical storm, or a VT storm, ICD is contraindicated. Why? Because there is no limit to how many shocks it will be giving. So, it will continuously keep giving shocks, right? It will continuously keep giving shocks. So, you do not go ahead and put an ICD in a VT storm. In fact, if there is a patient on ICD who is coming with an electrical storm, he will say that he is continuously feeling the shocks. Okay. So, that is going to be detrimental and it will progress to a VF and can lead to a cardiac arrest. So, there is no role of ICD in a VT storm. Fine? Okay. Now, let us understand about the ICD more. So, this is basically nothing but a pacemaker which is present in a subcutaneous, you have a pulse generator which is present in a subcutaneous pocket. Then you have leads which are coming out from that. So, this is your RA, this is your RV and LV or your ventricular leads. Okay, so what happens is that this is called as the shocking coil. This is your shocking coil. Okay, so what is the whole point is that this will detect the rhythm. If there is a VT, it will give a shock and terminate the VT. Okay, in some places, in some conditions, you can also give what is called as a CRT-D. What is the meaning of that? CRT we have already learned in our chapter on heart failure. It is your cardiac resynchronization therapy. Okay, so where do you use this? Cardiac resynchronization therapy is done in LV failure with bundle branch blocks, with RBBB or LBBB, so that it ensures that all the ventricles act synchronously. But in certain conditions, if this heart failure patient also has a risk of VT, then you combine this pacemaker of CRT along with a defibrillator, and this is what we call as a CRT-D. Okay, so what are the indications for an ICD? So, for primary prevention where a patient has not had a VT before, it is used in ischemic heart disease. So, in post-MI patients after 40 days or in post-PCI after 90 days. Why do we give this time frame? Because that is the time taken for the heart to recover. If after 40 days of an MI patient also there is a persistent LV dysfunction with an ejection fraction of less than 35% and the patient is in NYHA class 2 to 4, or the ejection fraction is less than 30% in an ischemic or a non-ischemic heart failure, then we consider putting an ICD. Because this is at a high risk of arrhythmias. But you don't go ahead and put it if the patient's life expectancy itself is going to be less than 1 year, right? So, you should consider that the patient's life expectancy is more than 1 year. Okay. Then, when do we insert an ICD for secondary prevention? So, they have already had a syncope of undetermined cause. And most likely you are attributing it to a VTVF. Then you don't want them to have another VTVF. You give it for secondary prevention. You do an EPS study in a patient with syncope of undetermined cause and you find that there is an inducible VT or VF. Then you go ahead and put an ICD so that they do not have recurrent episodes. Then, previous history of cardiac arrest with sustained VT or VF. Sustained VT is basically defined as a VT which lasts more than 30 seconds. Okay. So, the patient has already had a previous cardiac arrest with history of sustained VT or VF. Then, in conditions such as HOCM, Brugada syndrome or long QT syndromes, then you please go ahead and give them an ICD to prevent massive cardiac arrest or fatal cardiac arrest. Okay. And structural heart diseases with spontaneous VTs, you can also give a trial of ICD in these patients. Okay. So, that is about the indications and of ICD in a patient with VT. Okay. So, this brings us to the end of the discussion of ventricular tachycardias. I hope you have understood this topic well. Thank you.